Good evening, everyone. Today, I've titled the talk as RVOT obstruction. We tend to use the word pulmonary stenosis very loosely, when all that we want to say is that there is an obstruction somewhere in the right ventricular outflow tract. What is the right ventricular outflow tract? You can consider that it commences at the infundibulum, and it comprises the pulmonary valve and the pulmonary arterial tree. Therefore, I'll discuss today's various topics under the headings valvar pulmonary stenosis, subvalvar pulmonary stenosis, referring specifically to infundibular stenosis and double-chambered right ventricle, and supravalvar pulmonary stenosis, where we would refer to main or branch pulmonary artery stenosis and even lobar and segmental arterial stenosis in the pulmonary arterial tree. Isolated valvar PS, is a simple cyanotic malformation. The pulmonary blood flow is normal and may be diminished in extreme cases. The ventricular septum is generally intact, and this disorder accounts for 8 to 12% of all congenital heart defects in children and a slightly higher figure of adult congenital heart disease. It is no gender predilection. If we look at the genetics of it, non-syndromic pulmonary stenosis does not have any great genetic association, even though there may be some autosomal dominant-like inheritance in a few families. However, there's a specific or multiple specific syndromic associations for pulmonary stenosis, which includes Noonan, Williams, rubella, leopard. All these are syndromic associations when they exist. And the incidence of Noonan syndrome, if you take all cases of pulmonary stenosis, is perhaps around 7%. And for Noonan syndrome genetics, I'll refer to this again. The specific locus is in the chromosome 12q24.3, and mutations in the gene PTPN11 accounts for more than half the cases of Noonan syndrome. Clinically, when you look at pulmonary stenosis, it's easier to look at it as a neonatal, pediatric, or adult presentation. In the neonates, critical valvar PS is an emergency. It presents with profound hypoxia. And what do you mean by critical PS? It is severe PS with desaturation. And why does the desaturation occur? There is a right to left shunt across a PFO which may be sustaining life, because to maintain cardiac output, this right to left shunt is crucial. And pulmonary arterial flow itself is maintained by a persistent ductus. Tricuspid regurgitation is common in this. And the affected neonate obviously has cyanosis and tachypnea. When you examine the child, the first sound is normal, the P2 is delayed, soft or absent, and the murmur, if you hear any, would be the pansystolic murmur of tricuspid regurgitation or the continuous murmur of ductus. It could also be a mild stenosis, in which case all that you make out is an ejection systolic murmur and a phasic ejection click. The 2D echo appearance of this valve and the associated features are diagnostic. If you look at valvar PS in children, it is generally well tolerated, and even severe stenosis is often asymptomatic. If you examine the child, it's unremarkable from a general examination point of view, and atypical moon-like facies and chubby cheeks have been described in some children. In severe stenosis, the JVP may show prominent A waves. The apex beat is normal. A left parasternal heave is present if the stenosis is severe. And when you hear the S2, it's widely split. The P2 depends on the degree of severity of stenosis. In mild stenosis, it is well preserved. In severe stenosis, it's soft. And the auscultatory hallmark of valvar PS is the phasic ejection click. What is the phasic ejection click? It denotes a thin doming valve. It's caused by the abrupt cessation of the doming movement of the pulmonary valve. And this phasic click, remember, is the only right heart event which is louder in expiration. Why does it behave like this? This is because the doming pulmonary valve is pushed to a near open position in end diastole in inspiration because the RV is full. And therefore, with the onset of systole, the range of excursion of the pulmonary valve is very short, and therefore the click is dull. On the other hand, in expiration, the RV is less full and the pulmonary valve starts opening from a lower position. This wider range of excursion allows the pulmonary valve to dome more completely and generate the click. As stenosis progresses, the click comes closer and closer to the first sound. The S1 click interval is an index of the severity of pulmonary stenosis. In severe, very severe pulmonary stenosis, the click is so close to the first sound that you can't distinguish the two separately. Then how do you make it out? In the pulmonary area, you don't expect the first sound to be loud. You should hear the first sound loud over the apex or at best in the tricuspid area. So if you hear the first sound very loud and sharp in the pulmonary area, be suspicious and see in which phase of respiration you hear it better. If you are hearing it better in expiration, and if it appears like a first sound to you in terms of timing, you have made the diagnosis. This is a phasic ejection click. As I said, the click moves closer to S1 as stenosis progresses. The click is followed, of course, by the harsh ejection systolic murmur. And the more severe the stenosis, the peak of the murmur becomes later and later. It moves towards the second sound. So a long murmur with a delayed peak with an early click is the characteristic of severe pulmonary stenosis. The auscultatory hallmarks of severity are an early click, a long murmur with a late peak. In adults, Valvar PS does occur. There are a large number of adults that you are likely to see with Valvar PS. Anatomically, the valve may get more fibrotic or calcified as the person ages, and the clinical symptoms may vary from mild effort dyspnea, none at all, or to other extreme of signs of right heart failure. And moderate to severe obstruction leads to a lack of increase of the pulmonary blood flow with exercise. This can result in fatigue, syncope, or chest pain. And mild or moderate PS essentially has findings similar to what you described for children. You may find overt right heart failure. The JVP may show A waves. Cardiomegaly is common. The second sound is widely split, but P2 is often inaudible. Right ventricular third sound or fourth sound, probably both, may be heard. And TR murmur might overshadow the clinical findings. And in fact, features of right heart failure may overshadow the clinical findings. If you see the ECG, the baseline ECG is usually normal in mild or moderate PS, but in severe cases, right atrial enlargement, right ventricular hypertrophy, and right axis deviation are observed. An incomplete right bundle branch block may be seen, but if you find a left bundle branch block or left axis deviation in a child in whom you have diagnosed PS, think of Noonan syndrome. And the T wave, depending on the age, it may be upright or inverted, and you may find ST segment changes of RV pressure overload. And you must also know that it is possible to predict the right ventricular pressure. This is best in children aged from 2 to 20 years, and you can calculate this by multiplying the height of R wave in V1 into 5. R wave height in V1 into 5 gives you the RV pressure in millimeters of mercury, the RV systolic pressure. Look at this ECG. This ECG shows a sinus rhythm. You can see the tall peak P wave. So this is the right atrial enlargement. Look at the the negative QRS complex in lead 1 and the positive one in lead 3. It's a right axis deviation, and in fact, quite a bit of right axis deviation as the AVR is positive, and V1 is monophasic positive. So there is severe right ventricular hypertrophy, and if you see V6, there's a persistent S in V6. So you have different reasons to say that there is severe right ventricular hypertrophy in this patient. And if you see let's think that this R wave height is 20 millimeter. So 20 into 500 millimeters is the expected right ventricular pressure in this patient. Chest X-ray, the essentially heart and vascular markings are normal if the PS is only mild or moderate. But even in mild PS, the so-called post-stenotic dilatation is evident. If you see the X-ray, this hump is formed by the main pulmonary artery along with the beginning of the left pulmonary artery. Both the main pulmonary artery and the left pulmonary artery are characteristically enlarged in standard Valvar PS. If they are not, you should think of a dysplastic pulmonary valve. No doubt, echo is the best diagnostic tool for assessing pulmonary stenosis. You want to see the pulmonary valve anatomy. You want to localize the stenosis. Is it valvar only? Is it valvar? What is happening to the subvalvar region or the pulmonary artery? And the most useful views for these purposes are the high parasternal short axis and the subcostal sagittal views. But remember, your four-chamber view and the tricuspid regurgitation gives you a very reliable indicator of the right ventricular systolic pressure. And typical valvar stenosis would have a mildly thickened leaflets, and they would dome in systole. The valve may actually dome in pre-systole when the atrium is contracting vigorously when the stenosis is severe. If the valve is truly dysplastic, as in Noonan, it's markedly thickened. It seems to move very little. The annulus is small, and quite often there is supravalvar narrowing. So those are the features of dysplastic valves. They're thick, they don't move, there is no poststenotic dilatation, annulus is small, and they may be associated supravalvar stenosis. I hope you can see this video. Here, my pointer, sorry, hope to get it better. There is the valve which is doming, and the color flow through the apex of the doming valve shows that you are dealing with a severe stenosis because the jet width is very small. So this is a subcostal sagittal view which shows the doming pulmonary valve and the color flow Doppler showing the flow across it. And in a parasternal short axis view, this image won't move, I'm sorry. This is the doming pulmonary valve. The point that I want to make, look at the dilated pulmonary artery. This is the diameter of the aorta. If the main pulmonary artery is twice the diameter of aorta, obviously it is dilated. And look at the discrepancy between the right and the left pulmonary arteries. The left pulmonary artery is twice the size of the right pulmonary artery. This is because the jet of pulmonary stenosis tend to cling to the wall and is directed towards the left pulmonary artery. Therefore, it is the left pulmonary artery which is characteristically dilated. And you would align your continuous wave probe along the continuous wave cursor along the jet and measure the systolic velocity. One would say that it tends to correlate with the values that you get at cardiac cath, but it always has a tendency to exaggerate the value. The severity of pulmonary stenosis can be, estimated by looking at the gradient and looking at the RV systolic pressure. In mild PS, the RV systolic pressure is less than half systemic. In moderate PS, RV systolic pressure is 50 to 75%. of systemic, and in severe, it's more than 75% of systemic pressure. If you're looking at the gradient, in cath, the gradient is more reliable. Mild is less than 40, moderate is 40 to 60, and severe, you'll grade it as more than 60 to 70. Even though many textbooks would give the similar values for the Doppler gradients, if you take a Doppler gradient of 60 to 70, take this patient into the cath lab, you are likely to find a transvalvular gradient of maybe 40. Part of it is because of anesthesia. Part is also because the Doppler tends to exaggerate the value. So remember, most gradient-based recommendations are cath gradient-based recommendations. I want you to look at this pressure trace. When we are catheterizing, or before that, remember we do cardiac cath as a part of intervention, and the classical pressure tracing is a low or normal pulmonary arterial pressure with a high RV cavity pressure. RV EDP and RV A waves may be high, and right atrial A waves may be high, and the RV pressure will increase in the post-ectopic beat when ventricular septum is intact. I'll explain this. I hope you can make out this image well. This is a right ventricular trace in severe Valvar PS. Now, how do you say this is severe Valvar PS? This is the femoral artery trace, and here is the 100 gradient. So here, the femoral arterial pressure, the systolic, is around 80, whereas the RV systolic pressure is at least 120. So RV is suprasystemic. That is one. Second, look at the character of this pressure trace. It is an isosceles triangle. This isosceles triangle is a feature of the right ventricular pressure trace. It also tells you that the ventricular septum is intact. If there was a large VSD, the RV pressure would simulate the flat top pressure curve of left ventricle. The fact that you have the isosceles triangle is a feature of pulmonary stenosis with intact ventricular septum. When there is a ventricular ectopic beat, there is a rise in post-ectopic pressure. This rise in pressure will occur if only the ventricular septum is intact. If there is a large VSD, the pressure rise does not occur. So the rise in post-ectopic RV pressure is a pointer that the ventricular septum is intact. In this tracing, you can see that the pulmonary arterial tracing is not given, but the value is given. It's only 20 by 10, and RV is 120. There's a gradient of 100. And on this side, you find that this is the 50 level, 100 is here, the 100 line, and you find that now the RV pressure has become 50. The pressure characteristics are retained. It's still an isosceles triangle, but the systemic pressure has now gone up, and that has become 120. This is what happens when you open the valve. And when you do an angiogram, this is actually an angiogram along with a pulmonary valvotomy. I will not be discussing pulmonary valvotomy today. That's the topic of next class. They look at the valve here. This is the doming pulmonary valve, and the pulmonary artery and the LPA are dilated. So if you can make that out, the doming pulmonary valve along with the post-stenotic dilatation, that is the feature of pulmonary stenosis. Of course, the rest of the angiogram shows the balloon dilatation and the valve opening well after that. Mild PS, where we are speaking of PS with an RV systolic pressure less than half systemic and a cath gradient not exceeding 30 to 35 millimeters, it generally does not progress. But this statement applies to older children. If you are seeing a neonate with mild PS or an young infant with mild PS, you need to monitor that patient closely, maybe see every month or once in 2 months or 3 months, because it can progress. And the response to exercise in the older children is normal. in the first natural history study of 5 congenital heart lesions, only 3 out of 261 cases progressed to moderate PS. So mild PS in the older child, it generally doesn't progress. If at all it progresses to moderate PS. Whereas moderate stenosis and severe stenosis can be expected to progress. And in severe PS, the exercise cardiac output drops as the severity increases. Now, managing a child with mild PS, it does not require any intervention. You can follow it up every year if it's an older child. If it's a young infant, you will see maybe once in 3 months. And you don't need to limit exercise or activity level. Generally, infective endocarditis prophylaxis is not recommended in the current recommendations. If at the other extreme, if the patient has severe stenosis and there are right heart failure, you may treat judiciously with decongestive measures followed by intervention to relieve the obstruction. And in the adult with severe right ventricular dysfunction, even after opening the valve, the RV function may not completely recover. It does recover in some patients. And the goal of care for patients with Valvar PS is to intervene before RV dysfunction sets in. And the treatment of choice for isolated PS with a typical morphology is balloon pulmonary valvotomy. It is first done by genus scan, and it is indicated when a Doppler gradient is more than 60 millimeters of mercury or a cath gradient is more than 40 millimeters of mercury. Remember, in our national consensus guidelines, we chose the figure 6K for intervention. This is because, as I explained earlier, if you take a child with a lesser value to the cath lab, you will find that the cath gradient is maybe like 20 or 25 at the most, and you don't achieve much. That is why you put a figure like 60 on Doppler to take the child to the cath lab. If there is an RV dysfunction with an anatomically significant pulmonary stenosis, regardless of the gradient, you would intervene. And in a neonate with critical PS, there's an emergency for relieving the obstruction. Once the valvotomy is done, you need to follow up on the child, which would include clinical evaluation, ECG, and echo. You may do it at 1 month, 6 months, and 1 year after the procedure. And if the child is stable and there is no significant RVOT gradient, then you may follow up every year after that. And you could use ECG as an adjunct in the follow-up evaluation. Ordinarily, if there was severe RVH, it will slowly regress over a few months. It will take at least 6 months for you to see a clear regression of RVH in the ECG. If there is a Doppler gradient more than 50 millimeters of mercury, there is significant residual stenosis or restenosis if it's appearing later. And this is likely to occur if your balloon was small, or if you had an immediate gradient, or if your annulus is small, or if it's a post-surgical patient with a complex RVOT obstruction. If you follow up patients following balloon pulmonary valvotomy, nearly 3/4 of them have excellent outcome with minor gradients only and no indication for reintervention. This is more likely to happen in children with the classical Valvar PS morphology. If it's a dysplastic pulmonary valve, your results will not be great. And a small percentage would require surgical intervention because there is associated subvalvar or supravalvar PS. You do a balloon valvotomy and realize that your relief of gradient is either incomplete or at times no relief. This is when there is significant supravalvar or subvalvar addition to the outflow obstruction. Pulmonary stenosis does occur after balloon valvotomy, but the degree of PR is generally minor in most patients. There are a number of other catheter interventions that patients with pulmonary stenosis might require. As you know, in a patients with a severely hypoplastic right ventricle, it may need a balloon atrial septostomy. In a neonate with critical PS and hypoplastic RV, you may need to stent the ductus to maintain the saturation. in an older child, you may need to do a transcatheter closure of a significant size PDA. You may need to close an ASD, and in the adult, you may need to do a coronary artery angiography or even angioplasty in the adult with PS. When you need to do surgery, it is done under cardiopulmonary bypass. It may be a transpulmonary approach or maybe a transpulmonary plus transatrial if there is a subvalvular stenosis to be relieved. And the common reasons why we resort to surgery is for a dysplastic pulmonary valve which failed to respond to balloon dilatation. Then it might also require a transannular patch and a fixed infundibular or supravalvular stenosis along with pulmonary valve stenosis. These are the reasons for which you often require surgery. Let's make some reference to Noonan. You know that Noonan has the Turner phenotype as you see here, and the karyotyping is normal. The pulmonary valve in Noonan is thick and dysplastic. The annulus is small. There is no poststenotic dilatation. The ECG frequently shows left axis deviation. There is a suboptimal response to balloon pulmonary valvotomy. At times it may not respond at all. It is a tendency to be associated with hypertrophic cardiomyopathy, and Noonan with PS, more than half will have PTPN11 mutation. There are other systemic diseases like Leopard syndrome also has the PTPN11 mutation, carcinoid deposits, neurofibromatosis with its deposits in the pulmonary valve, glycogen storage deposits, other tumors, they all can be reasons for pulmonary stenosis. I should also add rhabdomyoma. Now from valvar PS, if we move away to the subvalvar region, isolated infundibular stenosis is a very rare thing. More often, infundibular stenosis is associated with a malaligned VSD and you call it tetralogy. The isolated infundibular stenosis is less than 5% of RVOT obstruction, and the anatomic substrate may be a fibrous band at the ostium of the infundibulum. Then this will resemble the DCRV because there are two chambers, and this entity sort of merges with DCRV. A fibromuscular obstruction can occur directly below the pulmonary valve. Very often, tetralogy has this type of an obstruction. This is an angiogram of an isolated infundibular stenosis. Look at the infundibulum here with the holdup of dye, and this is where the arrows point. You find the fibrous band marking the os infundibulum, and that is a feature of isolated subvalvular stenosis. Distinguishing this from DCRV becomes difficult. I'll come to that shortly. And the physical findings in these patients would include a widely split second sound with a soft P2, a loud ejection systolic murmur, a relatively lower location of the murmur. Mind you, valvar PS causes an ejection systolic murmur in the pulmonary area. The infundibular stenosis is lower down, third or fourth space. ECG features would be similar to PS. X-ray, there is nothing distinctive except that there is no main pulmonary artery dilatation. And in the echo, the pulmonary valve doesn't dome. It shows a systolic flutter. This is best seen in an M mode. You find the systolic fluttering of the pulmonary valve as the hallmark of subvalvular obstruction. Severity as estimated by continuous wave Doppler. And you can do an RV angiogram in the AP and lateral projections to show the site of obstruction. And you'll find that the narrowing is certainly more during systole and the pulmonary valve opens well. MPA is not dilated. Being infundibular stenosis, it would require surgical resection of whatever is the reason for the obstruction. Double-chambered right ventricle is a specific entity. It's a very distinctive anatomic entity where there is a muscular obstruction below the infundibulum. This divides the RV into a low-pressure infundibulum and a high-pressure inflow and apical portion. You can consider this as an abnormally located septoparietal band which is dividing the RV into an outflow and a region below the outflow with a lower pressure, and an inflow and apex with a higher pressure. The obstructive muscle bundles, they extend towards the RV apex. They have two characteristic locations. One can be low oblique, close to the apex, or a higher horizontal one close to the infundibulum. And the RV inlet is continuous with the apical trabecular portion that has a higher pressure, and the infundibular chamber has a lower pressure. It typically presents in infancy and childhood, but in children who have undergone correction of VSD or tetralogy may appear with DCRV in later childhood or adulthood. The commonest associated lesion is a perimembranous VSD, usually small. It may even get closed. You can get subaortic stenosis, then almost anything can occur along with it, but VSD is the classic association. And isolated DCRV with a mild to moderate outflow obstruction is asymptomatic, but severe RVOT obstruction would present with exertional fatigue, dyspnea, lightheadedness, or chest discomfort. And the associated lesions can make the presentation quite variable. And if there is an interatrial communication, or if the VSD is proximal to the obstruction, cyanosis can occur. Severe RVOT obstruction can result in a low left parasternal heave and a long ejection systolic murmur, no click. And remember, the RV stroke output is diminished, and the small proximal chamber and the subvalvular pressure is rather low, and because of this, the pulmonary valve tends to close early. As such, less output is negotiating the pulmonary valve, and the immediate subvalvular region has a lower pressure. This allows the valve to close early, so that you don't find too much of delay in the P2, and you don't find the P2 to be soft. ECG can show RVX and right axis deviation, but it may have some atypical features. For instance, you find a tall R in V4R, but V1 does not show a prominent R. And this is because of the absence of hypertrophy of the infundibulum. And chest X-ray may look absolutely normal, but supposing the obstruction is severe, you may find a reduction in the vascularity, or if the VSD with the left to right shunt is the dominant thing, you may find that there is an increase in the vascularity. In echo, you would identify the anomalous bundle just below the ostium of the right ventricular infundibulum in the short axis view. And you would appreciate the exact site of obstruction on color flow. And you can also see associated lesions like VSD. A transesophageal echo would help you to outline the degree of obstruction and the level of obstruction accurately. Again, I'm sorry this image doesn't move, but if you can identify that this is an outflow tract view, a short axis view, this is the pulmonary valve, and this is where the muscular obstruction will come. This is where the muscular obstruction will come, and the same thing will happen here. Here, this is the tricuspid valve. The outflow is beginning here only. This is the region where the obstruction comes. If this is the ostium of the infundibulum, the muscle hypertrophy seems to begin there and extend to the low infundibular and subinfundibular region. When you catheterize these patients, you find a low pressure tracing in the main pulmonary artery. You'll also find a low pressure in the infundibular chamber with no gradient across the valve, and the pressure shoots up while the catheter has been withdrawn into the RV apex. And in angiogram, best done in APN lateral or RAON lateral, you can see the obstruction as a pyramidal filling defect with its base broadly attached to the anterior ventricular wall and the apex protruding superiorly. I'll show that. Before coming to the angio, if you look at the pressure tracing, I'm sorry this is not completely clear. I hope you're able to see this. Here, you are in the pulmonary artery. The pressure is low. You're entering the RV There may be a small gradient of 5 or 10, but by and large, it's not very different in systole from the pulmonary arterial pressure trace. But as you are coming down, once you have escaped into the RV cavity, the pressure is suprasystemic. The pressure here has become, this is the 100 line. So the overshoot is exceeding 100. So the pressure is at least 100. And in the angiogram, look at this lateral view first. You can see a dense muscular obstruction here. And the infundibulum is here grossly dilated. You may not find this often. This is too classical. You may find a normal infundibulum. But you can see that there is a muscle bundle obstructing here and this dense trabeculation. And in the AP view, this is the pyramidal filling defect that I spoke about. The base of the pyramid is along the septum and the apex is pointing towards the outflow superiorly. And look at the degree of dense trabeculation. Once you have a significant gradient, like a 40 millimeter gradient on cath, it requires surgical resection of the obstruction. Now moving to the other important area of obstruction, namely supravalvular pulmonary stenosis. And pulmonary arterial stenosis or supravalvular stenosis refers to obstruction in the main pulmonary artery, its branches, or further distally. And the term peripheral pulmonary artery stenosis is used synonymously with this. There is a Gay and Smith classification on this, where look at the type 1, where you have just a proximal main pulmonary artery stenosis, the branches are okay. And type 2 is a bifurcation stenosis. And type 3 is a distal pulmonary artery stenosis on either side. And type 4 is a combination of multiple levels of obstruction, Gay and Smith classification. The causes of pulmonary artery stenosis are varied. They can be congenital or acquired. Congenitally, perhaps the common cause for pulmonary arterial stenosis that you see is in the left pulmonary artery at the point of ductal constriction. Remember, just as there is ductal tissue contraductally in the aortic wall, contraductally in the pulmonary arterial wall also there is ductal tissue that is prone to constriction, and you may find an isolated isolated LPA stenosis. It's very common as an association of tetralogy or tetralogy pulmonary atresia. In Alagille syndrome, pulmonary arterial stenosis is classical. So is the case in Williams, Neunan's, rubella. You may also get it in inherited disorders of connective tissue like cutis laxa, Ehlers-Danlos, and Silver syndrome. Acquired, following tetralogy repair, whatever you have done to the pulmonary artery, if you have done anything to the pulmonary artery, that site can potentially get narrowed. Following a tetralogy repair, arterial switch, where in the Lecomte maneuver they get stretched. When you have done a systemic pulmonary shunt at the receiving end of the shunt, when you have done a pulmonary arterial banding in the supravalvular MPA, when you have reimplanted the pulmonary artery in truncus or collaterals or an abnormal origin of RPA from the aorta, all these are causes of acquired stenosis. Following radiation, you can get a fibrosing mediastinitis which can involve the pulmonary arteries. Mediastinal tumors, Takayasu arteritis, all these can be causes for acquired pulmonary artery stenosis. Because of the diverse etiology, it is hard to estimate the incidence, and also the presentation can be quite varied from the neonate to the late adulthood. A diffuse peripheral pulmonary artery stenosis can present with life-threatening central pulmonary arterial hypertension in the neonatal period. The first patient that I saw this way was a case of cutis laxa. A post-op PA stenosis could manifest at any age, immediate post-op period to late adulthood. For instance, following a Glenn, if there is a pulmonary artery stenosis, the Glenn pressures are high and you would recognize it immediately. On the other hand, in a tetralogy, a mild stenosis can progress post-op into severe stenosis over a long period of time. And discrete pulmonary arterial branch stenosis, if they are isolated, may be asymptomatic, but it can worsen pulmonary regurgitation in a repaired TET, or it may cause congestive heart failure. Central PA stenosis, bilateral PA stenosis, or diffuse peripheral PA stenosis all may elevate central pulmonary arterial pressure and right ventricular pressure. Remember, many syndromic associations are there. So look for Noonan syndrome or Williams syndrome. Cyanosis may occur if RV pressure is high and a PFO is shunting right to left. JVP may show prominent A waves. You may have a left parasternal heave. S1 is normal, while S2 may be variably split. S2 may be loud because there is a central pulmonary arterial hypertension. You may get RVS3 or RVS4. Remember, the peripheral pulmonary arterial stenosis may be associated with a continuous murmur over the lung fields. In the chest X-ray, you may find RA enlargement. You may find MPA enlargement if both the bifurcation is stenosed or distal pulmonary arterial branches are stenosed. And if this is unilateral, the decreased vascularity on that side may be evident. And echo may show dilatation of RA, RV, and RVH. The nature and site of stenosis you may appreciate. And you can also estimate RV pressure from the TR on the Doppler signal. If you catheterize these children, you must remember that across a stenotic segment, a 10 millimeter gradient is significant, especially if it's a unilateral finding. Because in unilateral PA stenosis, the pressures in the main pulmonary artery and the right ventricle are normal. So you are not going to get a big gradient across a severe stenosis. And that is why I would point out that a 10 millimeter gradient is a significant gradient. But once you have bilateral pulmonary artery stenosis, MPA pressure rises. And the MPA pressure in bilateral pulmonary artery stenosis has certain characteristic features. One, it looks like the RV trace. It has a high systolic pressure and a low diastolic pressure. And the pulmonary trunk is now behaving as if it is an extension of the RVOT. Because even though the valve is there, the valve leaks liberally because the RV systolic pressure is very high. So RV outflow and the main pulmonary artery are in direct continuity, even in systole and even in diastole. And the obstruction is at the bifurcation or further on. A CT angio or MR angio would show the stenosis best, and a perfusion lung scan will show a ventilation perfusion mismatch. Indication for intervention in these cases would be an RV pressure more than 50% of systemic pressure, or a perfusion scan showing a decreased perfusion by more than 20% compared to the contralateral side, RV dysfunction or cyanosis, or the symptomatic patient. This is one illustration of a left pulmonary artery stenosis. This is actually in a post-Glenn patient. This is the SVC, and you find stenosis here. And this is actually a Williams syndrome where we were doing cutting balloon angioplasty. You can see that there are multiple areas of stenosis. In this image, almost every segmental artery is involved. If you watch the image without the balloon, you can appreciate stenosis at multiple segments. The details of transcatheter intervention I will not refer to because your very next class is going to deal with this. So therefore, right ventricular outflow tract may be obstructed anywhere from the infundibulum to the distal pulmonary arteries, and valvar and arterial lesions are amenable to catheter intervention. Infundibular and subinfundibular obstruction requires surgical repair. And regular follow of mild moderate lesions and a high index of suspicion can avoid silent progression of obstruction to right heart failure. Thank you. You're welcome to ask any question. Please ask your questions by chat. Acheta? Or how to decide the success of balloon pulmonary valvotomy? Okay, as I said, I did not discuss this because balloon pulmonary valvotomy would also be discussed on Thursday when Dr. Navneeta is dealing with interventions. But answering your question, if it is a neonate, if your RV pressure has dropped by more than 50% of the starting pressure, or if the gradient has come down to say less than 20 or 30, that is a successful balloon pulmonary valvotomy. In general, in balloon pulmonary valvotomy, following successful release, you will find that the immediate drop in pressure may be to near normal levels. So you find RV pressures which is less than half systemic. RV pressures which are less than half systemic denote a good outcome.